Hello and welcome. Today we're diving deep into a complex and often challenging heart condition called effusive-constrictive pericarditis. This condition represents a convergence of two distinct pericardial problems, fluid accumulation and constriction, leading to unique diagnostic and therapeutic challenges. Join us as we explore its causes, mechanisms, symptoms, and management strategies. Effusive-constrictive pericarditis arises from a variety of underlying causes, most commonly infections such as tuberculosis, viral infections, or bacterial infections. Autoimmune diseases like lupus and rheumatoid arthritis can also trigger this condition. Less frequent causes include cancer, radiation therapy, kidney failure, arrhythmia, and complications following heart surgery or other chest trauma. In some cases, the cause remains unknown, termed idiopathic pericarditis. The pathophysiology of effusive-constrictive pericarditis is a tale of two forces acting simultaneously. First, fluid accumulates within the pericardial sac, the membrane surrounding the heart, leading to pericardial effusion. This fluid buildup exerts pressure on the heart chambers, impairing their ability to fill properly and reducing cardiac output. Simultaneously, the pericardium becomes thickened, scarred, and constrictive, further restricting the heart's ability to expand and contract effectively. This constrictive element can be caused by inflammatory damage to the pericardium, leading to scar tissue formation. The combination of effusion and constriction creates a particularly challenging situation. The elevated intrapericardial pressure, caused by the effusion, transmits to the heart chambers, and the constriction limits cardiac output, causing systemic venous congestion. Effusive-constrictive pericarditis is a relatively rare condition, which makes determining its exact incidence challenging. Tuberculosis remains a significant cause in developing countries, while autoimmune diseases and post-cardiac surgery cases are more common in developed nations. The epidemiology varies depending on the geographic location and the prevalence of underlying risk factors. The signs and symptoms of effusive-constrictive pericarditis are often a blend of those seen in pericardial effusion and constrictive pericarditis. Patients may experience shortness of breath, dyspnea, especially when lying down, orthopnea, fatigue, and swelling in the abdomen, sites and legs, peripheral edema due to fluid retention. A prominent sign is Kussmaul's sign, an increase in jugular venous pressure during inspiration. Pulsus paradoxus, an exaggerated drop in systolic blood pressure during inspiration, may also be present. These symptoms develop gradually over time, worsening as the condition progresses. Diagnosis requires a comprehensive approach that combines clinical evaluation with various imaging and hemodynamic studies. Echocardiography is usually the initial test, revealing pericardial effusion and assessing ventricular function. Cardiac CT or MRI can provide detailed images of the pericardium, identifying thickening and constriction. Cardiac catheterization is the gold standard for confirming constriction by measuring intracardiac pressures. This can help differentiate from restrictive cardiomyopathy. Pericardial fluid analysis may be performed to identify the underlying cause, such as infection or malignancy. Effusive-constrictive pericarditis isn't typically classified into distinct types, but can be categorized based on the underlying cause, e.g., tuberculosis, autoimmune, or the degree of effusion and constriction. The severity of the constriction and the volume of the effusion greatly affect the presentation and management. Treatment and management strategies are tailored to the individual patient and the underlying cause. Initial management often focuses on addressing the effusion with pericardiocentesis, a procedure where a needle is used to drain fluid from the pericardial sac. This can provide temporary relief but may not address the underlying constrictive process. For patients with persistent constriction, pericardiectomy, surgical removal of the pericardium, is often necessary to relieve the pressure on the heart. Medical management involves treating the underlying cause, such as antibiotics for infection or immunosuppressants for autoimmune disease. Diuretics may be used to manage fluid overload but should be used cautiously as they can reduce preload and worsen cardiac output in the presence of constriction. Prevention of effusive-constrictive pericarditis focuses on managing the underlying risk factors. This includes prompt treatment of infections, careful management of autoimmune diseases, and meticulous surgical technique to minimize the risk of post-operative pericarditis. Early diagnosis and treatment of pericarditis, regardless of cause, may also prevent progression to effusive-constrictive disease. The prognosis for effusive-constrictive pericarditis depends on the underlying cause, the severity of the constriction, and the timeliness of treatment. Pericardiectomy can significantly improve symptoms and survival in patients with persistent constriction, with early surgery leading to better outcomes. Recent research focuses on improving diagnostic techniques to differentiate effusive-constrictive pericarditis from other conditions, such as restrictive cardiomyopathy, and on developing less invasive surgical approaches to pericardiectomy. Research is also ongoing to identify biomarkers that can predict the development of constriction following pericarditis.